Mask ventilation during tracheal intubation of critically 3 adults. Definition: it consists of the introduction of a tube in the trachea to ventilate a patient. This is done with the help of a laryngoscope for the visualization of the glottis. It is usually done orally, but it can also be done nasally.
Ensure that the equipment is prepared and check that the laryngoscope is working and the cuff on the tube inflates and deflates properly. Pre-oxygenate the patient with bag and mask ventilation for up to 1 minute before attempting to intubate. Standing behind the patient with the head in the sniffing the morning air position, with the left hand, insert the curved blade of the laryngoscope into the mouth over the right side of the tongue, displacing it to the left and upwards. Advance the laryngoscope slightly until the tip of the epiglottis can be seen posterior to the back of the tongue. Advance the tip of the laryngoscope blade into the vallecula between the epiglottis and the tongue. With the handle of the laryngoscope pointing away from you at 45 degrees, lift upwards and away to lift up the tongue and epiglottis to display the vocal cords and the laryngeal opening. With the right hand, insert the endotracheal tube from the right-hand side of the mouth directly between the cords and into the trachea until the cuff passes through the cords. The markings on the tube at the incisors will show between 21 and 24 centimeters in the average-sized adult when the tube is in position. Remove the laryngoscope and inflate the cuff with approximately 15 mL of air to prevent air leaking during ventilation. Attach the tube to the bag and valve apparatus and ventilate the patient with the oxygen flow on 12 to 15 liters per minute. Confirm the position of the tube by auscultating over the apices of the lungs, the axillae and the stomach. If it is not in the correct position, deflate the cuff and remove the tube. Resort back to bag and mask ventilation and repeat the intubation process from the beginning.
Application in nursing: patient monitoring, checking the pads, lubricate the tube and guide. In the doctor consider it necessary, keep them in a proper position to prevent aspiration, and the tube with strictly aseptic.
To perform the process of intubation, basically two things are required. First one is endotracheal tube and the second one is a laryngoscope. Laryngoscope is having two parts. First one is the handle of the laryngoscope and the second one is the blade of the laryngoscope with point source of light. Now we are going to start the process of intubation. Now to perform the process of intubation, slightly extend the neck of the patient. Now we are going to introduce the laryngoscope. Gradually introduce the laryngoscope, and as soon as you are going to introduce the laryngoscope, you people can see this uvula, tonsil and the epiglottis which is covering the trachea. You are supposed to introduce the blade just behind the epiglottis and lift it. As soon as you are going to lift the epiglottis, you people can see there is an opening for the trachea. This opening is characterized by the presence of vocal cords which are placed laterally, and in this opening you are supposed to introduce the endotracheal tube. Unless and until this opening is not visible, you are not supposed to introduce the endotracheal tube. Here we are going to introduce endotracheal tube. Endotracheal tube should be introduced into the trachea. After the introduction of the endotracheal tube inside the trachea, you are supposed to inflate the bulb which is present distally at the end of endotracheal tube. Now gradually remove the laryngoscope, remain as it is. In that condition, you people can take the chest X-ray to look whether the endotracheal tube is placed in situ or not. Now, finally, after removing the ambu bag, you are supposed to attach the endotracheal tube with the hand ventilator. This is how the process of intubation is done.
Pros and cons. Water positive pressure ventilation with a bad mask device during tracheal intubation of critical is thought prevent hypoxia without increasing the risk of aspiration pregnant controversial. Cons. Hypoxia is the most common complication during tracheal intubation of critical its adults and may increase the risk of cardiac arrest and death. Issue apply in Ecuador a those undergoing tracheal intubation to receive in ventilation with a bad mask device or without ventilation between induction and laryngoscopy. The primary result was the lower oxygen saturation observed during the interval between induction and 2 minutes after tracheal intubation.
The rationale of the study is based on the question that under tracheal intubation is still discussed to take care of patients with cardiac arrest out of the hospital. And especially since in the last years, some studies issued from registries have demonstrated that bag mask ventilation, that is an easier way to take this patient in charge, could have better results in terms of survival with good clinical and especially good neurological outcomes for these patients. And the results of these observational studies were so good that, we wanted to know exactly if we can change our practice and the way to take in charge of patients and go to the bag mask ventilation rather than the endotracheal intubation. The study design is a randomized clinical trial with non-inferiority hypothesis, and we calculate that a sample size of 1,000 patients per group will allow us 80% power to demonstrate non-inferiority with a non-inferiority margin of 1%. And the primary outcome of the study is survival at 28 days with good neurological outcome. And the secondary outcomes included return to spontaneous circulation and survival at admission and adverse effects.
Conclusion. In study carried out, they showed among critical its adults undergoing tracheal intubation patients receiving a bad mask ventilation had varied oxygen saturation and a lower incidence observed hypoxia The top receives no ventilation.
This video will demonstrate bag mask ventilation of the patient. One provider at the head of the patient. The pre-hospital care provider kneels above the patient's head, providing manual stabilization of the patient's head and neck in a neutral inline position with his or her knees. After the insertion of an airway adjunct, OPA or NPA, the mask is fitted over the patient's nose and mouth and held in place with firm downward pressure while keeping the airway open. This can be accomplished by placing the third, fourth, and fifth fingers around the mandible and applying slight upward pressure. Wrapping the thumb and first finger around the mask at the mask and bag attachment point, forming a C. Either adequate hand pressure is used or the bag is pressed against one's own body, for example, the thigh, to squeeze the air or oxygen from the bag and into the patient's lungs. The patient's chest is looked at to assure adequate rise with each breath delivered. One provider at the head of the patient inserting an OPA. OPA insertion should only be performed in patients without a gag reflex. Position yourself above the patient's head, with one knee on each side of the patient's head with slight inward pressure. After insertion of the OPA, encircle the mask with your thumb on the nose part of the mask, and your first 2 or 3 fingers on the jaw part of the mask. Hook your little finger or ring finger and little finger under the lower mandible to keep the mandible elevated and to avoid any loss of the seal with movement of the chin. The patient's chest is looked at to assure adequate rise with each breath delivered. 2 providers with bag mask. When 2 providers are available to assist the patient's ventilations with a bag mask, one provider maintains the head and neck with neutral inline stabilization while holding the face mask in place. The first provider kneels above the patient's head and maintains manual stabilization of the patient's head and neck in a neutral inline position. Their forearms